Hi everybody, welcome to our module on pulmonary circulation. So let's start with a very brief review of the way blood moves through the lungs. So venous blood with low oxygen empties into the right ventricle of the heart. From there it goes to the pulmonary artery. From there it goes to the capillaries around the alveoli where it picks up oxygen. Then it empties into the pulmonary veins and then it drains into the left atrium and then gets pumped out to the body. The pulmonary circulation is a low pressure system, so recall that the systemic blood pressure is about 120 over 80 under normal conditions. The pulmonary artery pressure, in contrast, is about 24 over 12. And the reason it's lower is because it doesn't need to go as far. Pressure is the driving force for flow, and the blood in the pulmonary artery just needs to go to the top of the lungs. On the other hand, the blood in the systemic circulation needs to go everywhere from the head down to the feet, so that requires much more energy and therefore much more pressure. Because the pressure is lower, the walls of the pulmonary artery are very thin. There's very little smooth muscle, and there's relatively low resistance to flow, especially compared to the systemic system. And these pulmonary artery walls are very distensible and compliant because they are so thin. It's important that you understand the effects of blood oxygen content on the pulmonary circulation. So in the systemic circulation, when you have a low oxygen level, this leads to vasodilation. The systemic circulation interprets a low oxygen level as insufficient blood flow, so they will vasodilate to increase the blood flow, and this is what keeps your tissues, like your muscles, from being deprived of oxygen. In the pulmonary circulation, the opposite happens. When you have a low oxygen level, this leads to vasoconstriction. Why is this the case? Well, this is a process called hypoxic vasoconstriction, and the idea is to shunt blood away from poorly ventilated areas. The lungs will interpret a low oxygen level as meaning that portion of the lungs is not working, and they don't want to waste blood flow in that area, so they will vasoconstrict and shut down the blood flow, and this will send more blood to well-ventilated areas. And this is very important for the fetal circulation. The low oxygen level constricts the pulmonary arteries in the womb, and this makes less blood flow go through the lungs, which aren't important when the baby is inside the mother. At birth, the arteries receive O2 and then they dilate and you start to get blood flowing through the lungs. So if we were to graph the oxygen level on the x-axis and the blood flow on the y-axis, we would see that in the lungs, as the oxygen level goes up, the blood flow goes up, and as the oxygen level goes down, the blood flow goes down. The systemic circulation is the opposite. Way down here where the O2 level is low, there's a lot of blood flow because those vessels are vasodilating. Up here where the O2 level is high, there's relatively little blood flow. Make sure you understand that these two systems have opposite responses to changes in oxygen content. Now let's talk about the diffusion of gases. So the gases have to diffuse from the air to the blood in order that oxygen can get to red blood cells and help the body. And the rate of diffusion depends on three things. The first is the pressure difference. So if there's a high pressure of oxygen in the air and a low pressure in blood, that drives diffusion. Another factor is the area of the alveoli. The more area there is, the more gas that can diffuse. And then the final factor is the thickness of the alveolar tissue. If the alveolar tissue is very thick, it's hard for gases to diffuse across. And if it's very thin, it's easy for gases to diffuse across. So this is just a picture that illustrates those concepts. So the difference between the pressure here and the pressure here will drive diffusion. The more pressure difference there is, the more diffusion that will occur. The area here influences diffusion. If there's more area, you can get more diffusion. And then finally, the thickness is a factor. The thicker the area that the gas has to diffuse across, the less diffusion that will occur. And we can write this in an equation by saying that the rate of gaseous diffusion is equal to the area divided by the thickness times a constant d times the pressure difference. And just like what I showed you before, if you have more area, you get more diffusion. If you have a greater pressure difference, you get more diffusion. And then the thicker the area is that you have to diffuse across, the less diffusion that occurs. And there are some pathological correlates to this equation. So the area for diffusion falls in emphysema. In emphysema, alveoli get destroyed and there isn't much area, so there's less gas diffusion, and that's why patients can get hypoxemic and develop high levels of carbon dioxide. The thickness rises in pulmonary fibrosis. So when you have fibrous tissue laid down, it makes the alveoli and the lungs very thick, and it's hard for gas to diffuse across those. So in both conditions, you get poor diffusion, and this causes hypoxia and elevated levels of carbon dioxide because you can't bring the oxygen into the body and you can't get the CO2 out. Now I'm going to talk about a very important concept, and that is diffusion versus perfusion limitation of gas uptake by the blood. And the way that this concept is classically explained is by going through the graph shown on the screen here. So we're going to work through this graph in the next few slides. So this graph shows what happens to three gases, carbon monoxide, oxygen, and nitrous oxide, as they move along the length of a capillary in the lungs. It shows what happens to their partial pressure. So let's imagine that we have a capillary in the lungs, and blood is entering that capillary and blood is exiting that capillary. Next to the capillary we have an alveolus, and it's got a partial pressure of various gases inside the alveolus. Well, blood that passes through this capillary is going to leave with a partial pressure of various gases, either oxygen, nitrous oxide, or carbon monoxide. And what that graph shows is what happens to this partial pressure in the blood as the bloodstream moves along the capillary in the lungs. So let's go back to this graph now, and we'll start by looking at nitrous oxide. So when blood enters a capillary, there's no nitrous oxide because normally no nitrous oxide is found in our venous blood. But as blood moves along the capillary, it picks up nitrous oxide until nitrous oxide reaches the concentration that's in the alveolus. So in other words, nitrous oxide reaches full equilibrium with the gas in the alveolus, and therefore its concentration maximizes at that level. It cannot go any higher than the partial pressure found in the alveolus. Carbon monoxide, on the other hand, sees its level rise somewhat. There's no carbon monoxide initially when blood enters the capillary, and it rises somewhat, but it never reaches equilibrium with the alveolus. There's always a difference, and we're going to have to explain that in the next few slides. And then finally, oxygen is somewhere in the middle. It also reaches equilibrium with the pressure of gas in the alveolus, but it takes a little bit longer to do that compared with nitrous oxide. So in the next few slides, we'll make sense of this graph, and in order to understand it, you have to appreciate three things. For the concentration of gas in the blood to rise as blood moves through a capillary in the lungs, first of all, gas must diffuse across the alveolar membrane, and then perfusion must carry the gas away from the lungs. And then finally, the gas cannot dissolve in the blood. If it dissolves in the blood, then it won't be able to exert any partial pressure as a gas, and therefore the partial pressure in the blood will not rise. So to understand this better, let's do a little thought experiment. Let's imagine we've got some gas molecules stored inside a chamber, and they are separated from flowing blood by a membrane shown here in brown. And then let's imagine that we've got a detector at the end here so that as blood flows past the membrane, we can detect the partial pressure of the gas in the blood. So what will happen is gas molecules will begin to diffuse across the membrane, and they will be picked up by the flowing blood. And then as more blood flows, it will pull more gas molecules in, and the partial pressure of the gas in the bloodstream will begin to rise. In the case of nitrous oxide, what happens is this diffusion barrier here is no factor whatsoever. Nitrous oxide easily moves through this, and then it is quickly picked up by the blood. What that means is the partial pressure rises rapidly in the blood, and the only factor limiting how much nitrous oxide molecules move into the blood is the perfusion. In other words, if you perfuse more blood, you will pick up more nitrous oxide. If you perfuse less blood, you will pick up less nitrous oxide. Therefore, nitrous oxide is said to be perfusion limited in terms of its ability to be picked up by the blood. Contrast that with carbon monoxide. So for carbon monoxide, this barrier here, the alveolar membrane, is a major barrier, and it's very hard for molecules to get past that. This means that even when you flow more blood past the membrane, you don't pick up more gas because you just have to wait for the molecules to work their way through the membrane. This means that it's going to take longer for the partial pressure of carbon monoxide to rise in the blood, and in fact it's not going to have enough time as it flows through the capillary to reach equilibrium with the alveolus. Therefore, what we say about carbon monoxide is that it is diffusion limited because it's limited by its ability to diffuse across this membrane. Now, a second problem for carbon monoxide is that, as you may know, it can bind to hemoglobin. That's why it can cause poisoning. So in addition to carbon monoxide taking a long time to work its way past the membrane, once it gets into the blood, a lot of the carbon monoxide binds to hemoglobin and does not exert a partial pressure. So this is kind of a double whammy. It's tough to get across the membrane, and once it gets across, some of it binds to hemoglobin and does not raise the partial pressure of the gas. Therefore, the partial pressure of the gas rises relatively modestly compared to nitrous oxide, which has no diffusion limitation. Now, of course, we don't normally inhale nitrous oxide and carbon monoxide. Those are just used as examples of ends of the spectrum in terms of diffusion or perfusion limitation. But let's talk about oxygen, which is very important. So in normal, healthy subjects, oxygen uptake is perfusion limited. However, when patients develop disease like fibrosis or emphysema, it makes it much harder for oxygen to get across the alveolar membranes. And in this situation, oxygen uptake can become diffusion limited. So now let's go back to this slide and see if we can make sense of this. So in this slide, we've got the length along the capillary on the x-axis and the partial pressure of gas in the bloodstream on the y-axis. The highest partial pressure in the bloodstream any gas can achieve is the partial pressure of that gas in the alveolus. You cannot get any higher than this. Once the gas partial pressure in the blood is the same as that in the alveolus, then the alveolus and the blood are in equilibrium. So let's start by looking at nitrous oxide. So venous blood coming into capillaries has no nitrous oxide, therefore the partial pressure will be zero. However, the partial pressure rapidly rises and reaches equilibrium with the alveolus, and that's because nitrous oxide is perfusion limited. In the case of oxygen, when blood enters the capillary, the partial pressure of oxygen is not zero. Remember, we have some oxygen in our venous blood, but it's also not as high as the partial pressure in the alveolus. And then, like nitrous oxide, oxygen under normal conditions is perfusion limited, so it reaches equilibrium with the alveolus. Carbon monoxide, on the other hand, is down here at the bottom. So the partial pressure of carbon monoxide in the blood is initially zero when it enters the capillary. And then if we're administering carbon monoxide to a patient, that level will rise, but it will not reach equilibrium with the alveolus. And that's because of the reasons we just talked about. Carbon monoxide is diffusion limited, and it also binds to hemoglobin in the blood. So during the time it has in the capillary, it's never able to reach equilibrium with the alveolus. The fact that carbon monoxide is diffusion limited has an important clinical application, and that is a pulmonary test called the DLCO. DLCO stands for the diffusing capacity of carbon monoxide. This is a test done in patients with lung disease to measure the ability of the lungs to transfer gas. The way this test works is that the patient inhales a small amount of carbon monoxide that is not dangerous. And because carbon monoxide is diffusion limited, the amount that is taken up by the blood will be proportional to the diffusion function of the lungs. A machine then measures the amount of carbon monoxide that is exhaled, and the difference between the inhaled and the exhaled is the amount taken up by the blood. The machine then calculates a DLCO and compares it to a percent predicted for the patient based on age and other factors. Normal is 75 to 140% of predicted. In patients with severe limitations to uptake of gas due to lung disease, it can be less than 40% predicted. And I talk about this in some of the videos on lung disease, but the point for you to understand here is that the reason carbon monoxide is used as a gas in this test is because it is diffusion limited. So let's look at what would happen to oxygen in terms of diffusion perfusion in disease. So the red line here is a healthy individual, and the oxygen level rises up to the concentration of oxygen in the lungs. In a patient with disease, however, remember, oxygen becomes diffusion limited, so it can't get all the way up to that maximum value. This means that the concentration of oxygen in the bloodstream is going to fall, and this is part of the mechanism by which patients become hypoxemic when they have lung disease. Let me also mention what happens to these curves for oxygen at rest versus exercise. So at rest, the blood is flowing relatively slowly as it moves along this capillary on the x-axis. The result is that it has lots of time to pick up oxygen, and it more quickly picks up the oxygen and reaches the maximum value, that value found in the lungs right here, P sub A. With exercise, the blood is flowing faster because your heart pumps faster with exercise. This means the blood is able to get further along the capillary before it reaches the maximum value. However, you should note that it does still reach the maximum value even in patients who are exercising. And so you should know that exercise alone should not make someone hypoxemic. Some patients with lung disease do get hypoxemic when they exercise, but it's not just because of the exercise, it's because they have a problem with their lungs. The next topic I want to discuss is pulmonary vascular resistance. And what I'm talking about here is the resistance to blood as it flows through the lungs. And it turns out there are two vessel types which determine how much resistance there is to blood flow. The first type are the alveolar vessels, the blood vessels that supply blood to the alveoli. And the second are arteriolar vessels. These are vessels that supply blood to the lungs that are extra alveolar. They're outside the alveoli. And both of them contribute to the amount of resistance to blood flow. When you take in a breath, you increase the lung volumes, and this stretches the alveolar vessels. It makes them longer with a smaller diameter, and this increases their resistance to flow. When you exhale, you decrease lung volumes, and this is good for the alveolar vessels. They want decreased lung volumes. However, those extra alveolar vessels, the arteriolar vessels, become narrow when the lung volumes go down, and this increases their resistance. The result is that you have a push-pull, so the alveolar vessels want the lung volumes to be small, and the arteriolar vessels want the lung volumes to be high. This means that your pulmonary vascular resistance, which I've shown down here on this chart, changes as you take in a breath and as you exhale. And it turns out the point at which the total pulmonary vascular resistance is lowest is the functional residual capacity, the FRC. Right between when you exhale and begin to inhale, you're at that FRC, and that's where you found a happy medium between the alveolar vessels and the arteriolar vessels, and the pulmonary vascular resistance will be lowest. Now let's talk about pulmonary hypertension. So recall that a normal pulmonary artery pressure is about 24/12 with a mean pressure of 10 to 14 millimeters of mercury. Pulmonary hypertension occurs when the mean pressure is greater than 25. And it's very high yield to know for your boards that pulmonary hypertension gives you a loud P2 when you examine the patient with your stethoscope. Look for question stems that mention an accentuated or loud second heart sound at the left upper sternal border. They're trying to tell you that that patient has pulmonary hypertension. The main symptom of pulmonary hypertension is dyspnea, and if it's untreated, it can lead to a clinical syndrome called cor pulmonale. This is when there's chronic high pressure on the right ventricle. The right ventricle will hypertrophy, and then eventually it'll start to dilate and fail. And when your right ventricle fails, you get clinical signs like jugular venous distension, lower extremity edema, and you can get hepatomegaly and even cirrhosis. And patients with untreated pulmonary hypertension die from heart failure or arrhythmias. The gold standard for diagnosis of pulmonary hypertension is to do a right heart catheterization. This involves inserting a catheter into the pulmonary artery and directly measuring the pressures. Now this is invasive, so we only do this when we need to. There's a non-invasive way to estimate pulmonary pressures, and that's by using an echocardiogram. This can see the flow of blood across the tricuspid valve and use it to estimate the pulmonary pressure. It can also visualize the right heart structure so you can see if the right ventricle is hypertrophied or enlarged. To understand the causes of pulmonary hypertension, we need to go back to a little basic physics. You probably at some point in your life learned about Ohm's law as it relates to an electrical circuit. And Ohm's law states that the voltage in an electrical circuit is equal to the current in that circuit times the resistance. But really, Ohm's law is just a statement of a general principle which says that the energy required to drive something through a circuit, that's V, is equal to the speed at which you want to move, that's I, and the resistance to movement, and that's R. And this applies to fluid systems just like it does to an electrical circuit. So for fluids, the energy that drives fluids through a system is the change in pressure. The speed at which things move through that circuit is the flow rate Q, and the resistance is R. So using this second equation I've shown right here, we can create a flow equation for the lungs, saying that the energy needed to drive fluid through the lungs is the change in pressure times the cardiac output. The entire cardiac output goes through the lungs times the pulmonary vascular resistance. This is easier to understand if we draw a picture, so I'll draw two lungs here, and the fluid that is going into the lungs is coming from the pulmonary arteries. So the pressure of this fluid is going to be the pressure in the pulmonary artery. And let's just say, for argument's sake, that this is a pressure of 20 millimeters of mercury. So we have a pressure or driving force of 20 pushing fluid into the lungs. Fluid that leaves the lungs exits and goes into the left atrium. So the pressure of fluid leaving the lungs is the pressure of the left atrium. And let's just say, for example, that that's 5. What this means is that we spent 15 millimeters of mercury worth of pressure or energy moving fluid through the lungs because we went from 20 to 5. So the delta P across the lungs would be 15. Now what did we get for all that force or energy that we spent? Well, we drove the entire cardiac output through the lungs, and we pushed that entire cardiac output through a system with a resistance called the PVR, or pulmonary vascular resistance. So in other words, 20 minus 5 has to be equal to the cardiac output times the PVR. This is the application of the flow equation to the lungs. So the reason I went through all that is because if you understand the flow equation, it's really easy to understand the causes of pulmonary hypertension. We said when we made our drawing that the delta P across the lungs is equal to the pressure in the pulmonary artery minus the pressure in the left atrium, which equals the cardiac output times the PVR. If we rearrange this equation and solve for the pressure in the pulmonary artery, we get that the pulmonary artery pressure is equal to cardiac output times PVR plus the pressure in the left atrium. And if you know this, you can understand all the causes of pulmonary hypertension. You can get pulmonary hypertension, which means an elevated pressure in the pulmonary arteries, if you have a high pressure in the left atrium. You can also get high pressure in the pulmonary arteries, which is pulmonary hypertension, if you have a high cardiac output or a high PVR. On this slide, I've added some more details about the many causes of pulmonary hypertension. So pulmonary hypertension is high pressure in the pulmonary arteries, just like systemic hypertension is high pressure in the systemic arteries. And the pressure in the pulmonary arteries is dictated by this equation, which we just derived on the last slide. The most common cause of high pressure in the pulmonary arteries or pulmonary hypertension is high left atrial pressure. This is called pulmonary venous hypertension because there is high pressure in the pulmonary veins that drain into the left atrium, and that pressure is being transmitted backwards into the pulmonary arteries. And the causes of high left atrial pressure all relate to the left ventricle. So left ventricular heart failure or valve disease that involves the left ventricle, these things are very common. They often raise the left atrial pressure, and that leads to pulmonary hypertension. You can also have pulmonary hypertension from high pulmonary vascular resistance. This is called pulmonary arterial hypertension to distinguish it from pulmonary venous hypertension, because when the PVR is high, there is high pressure in the pulmonary arteries but not in the pulmonary veins. And this can be a primary or secondary problem, and we'll talk more about that in a minute. And then finally, rarely a high flow state can raise the cardiac output, and this can cause pulmonary hypertension. This occurs especially in children with large left to right shunts, like large ASDs, VSDs, or PDAs. This floods the lungs with fluid and raises the cardiac output moving through the lungs, and that causes pulmonary hypertension. So as you can see, there are many different causes, but they're all easy to remember if you just know this flow equation. One of the causes of pulmonary hypertension, as I just told you on the last slide, is high pulmonary vascular resistance. Now, this can be a primary problem. That's called primary pulmonary hypertension. We'll talk about that in a minute. But there are many secondary causes of high pulmonary vascular resistance, and most of these are lung diseases which raise the resistance to flow as blood moves through the lungs. So COPD is a classic secondary cause of high pulmonary vascular resistance and therefore a secondary cause of pulmonary hypertension. You can also have pulmonary hypertension from chronic pulmonary emboli. You can see this in pulmonary fibrosis, like people with scleroderma develop. People who have sleep apnea or live at high altitudes have chronic hypoxia, and this constricts vascular beds in the lungs, and that can raise the PVR. And then finally, end-stage HIV is associated with pulmonary hypertension from raising the pulmonary vascular resistance. Primary pulmonary hypertension is a rare disease where the pulmonary vascular resistance goes up for unclear reasons. It classically affects young women, and one thing we do know is that people with this condition have increased endothelin, which is a vasoconstrictor, and decreased levels of nitric oxide, which is a vasodilator. The result is that they get vasoconstriction of their pulmonary vasculature and they get smooth muscle proliferation, and this all leads to high pulmonary vascular resistance and high pulmonary pressures. There is a gene mutation that's been discovered that's associated with many cases of primary pulmonary hypertension. It's called the BMPR2 gene mutation. That stands for bone morphogenic protein receptor type 2. This mutation is found in about a quarter of idiopathic cases of pulmonary hypertension and about 80% of familial cases. Familial primary pulmonary hypertension is very rare, but the cases that do exist often have a gene mutation of BMPR2. And people with this gene mutation have abnormal endothelial and vascular smooth muscle growth and proliferation, and this leads to thickening of the pulmonary vessels and increases the pulmonary vascular resistance and the pulmonary pressures. Women who develop pulmonary hypertension get progressive dyspnea over time, and if it's untreated, they'll get right heart failure and they'll die of heart disease. There are 3 treatments that are used, and these are all treatments that lower the pulmonary vascular resistance. The first one is epoprostenol, which is also called prostacyclin. This is an IV drug, and women who take this have to have an indwelling catheter to infuse it constantly. This used to be the only drug available, and it was very cumbersome to use. There are now a couple of pills that are used instead, so epoprostenol is not used that much anymore. The first one is bosentan. This is an antagonist of endothelin-1 receptors, and this will vasodilate the pulmonary vascular bed and lower the pressures. The other drug is sildenafil, which you may know as Viagra for erectile dysfunction, but it's a vasodilator, and it also works in people who have pulmonary hypertension. It inhibits phosphodiesterase 5 in the smooth muscle of the lungs, and this will lower the pulmonary vascular resistance and improve the pulmonary pressures in women with pulmonary hypertension. And that concludes our module on pulmonary circulation.